Well, everyone's favorite topic, certainly one that's gotten a lot of traction on YouTube, but it is something that happens, and we need to be prepared to deal with. So, I'll share my thoughts. Obviously, if any of the fellows or anybody have any questions, just stop me and we can discuss. For the first time in I think 4 years, I've actually got one or two new slides. So there have been some new things in the field of spinal fluid leak management, which we'll briefly discuss. So, obviously, there are two types of spinal fluid leaks to deal with. One is a planned durotomy for intradural pathology, and the other is an iatrogenic or unplanned durotomy. I would just say to our fellows, if you can come in for a case or hopefully more than a case of intended durotomy, it's very useful. Whether or not you do it in your practice, it's still useful to have an opportunity to close the dura when it's a clean tear and or a clean opening, and we've got time and people aren't stressed out because it's a complication. So this is actually a dural closure after a tumor section by one of our former fellows, Ryan, who did a really nice job, and he told me a year ago at a meeting that it helped him just having that opportunity to throw 25, 30 stitches in the dura in a relatively controlled environment. So Mike, David, if you get a chance to, please scrub in with me on these cases, and we can at least get used to throwing some stitches in the dura. But the focus of today's talk, which is unfortunately the majority of dural openings, are unplanned durotomies or iatrogenic durotomies that happen incidentally during the course of spinal surgery. So here's just a couple of pictures of what that looks like. In terms of incidence, there's really no consensus. I think, as you might imagine, it's a difficult thing to study with accuracy just because of challenges in reporting. And as a result of that, there is quite a bit of range, but it's common. And the incidence ranges from 1%, which I think is definitely not true, up to 17%, which seems way too high, depending on the study. So there's quite a bit of range, and there are a few studies that have tried to circumvent self-reporting bias to get a better sense of the true incidence using like language learning models and national health databases. So we'll touch on those briefly. This one comes out of the UK. Obviously, where you've got a national healthcare system, it's easier to collect quality data because you just have one unifying body. And it studied all the dural tears amongst spine surgeons in the UK. It was done prospectively, and they looked at almost 1,600 cases across 14 different hospitals in the UK. And in that study, they found a bit of a range depending on the procedure that you were performing. So about 3.5 for just a microdisc, quite a bit higher, 8.5% for spinal stenosis. That does seem high to me, but that's what was found. 13% for revision discectomy seems a little high, but certainly the 10% increase compared to primary discectomy seems somewhat appropriate. I mean, it's a dramatically increased risk given the efforts to dissect scar away from the dura and how those things can be tethered and adherent. And then, not surprisingly, there's a wide variation among spine surgeons. I would say that's probably true in practice, but no spine surgeon is immune. The best spine surgeon in the world is going to have a couple CSF leaks a year. And so we all have to be ready and willing to deal with it. I think because of the variance that there is in the literature, it's useful to collect your own data. So this is just a redacted form of my spreadsheet where all my surgeries go into, and I have a column for complications. Obviously, there's some issue that day or those 2 days because I had two durotomies back to back, but then you can very quickly just run a macro on Excel and determine what your CSF risk is for discs, revision discs, stenosis. And then when you're telling a patient, the risk is about whatever X%, that it's not just sort of BS or data that you're trying to extrapolate from some study from the UK, but rather a pretty good risk assessment of the procedure in your own hands. And that way they can make an informed decision. I would just say that like when I'm counseling people for a microdisc or lumbar stenosis, it's probably the one thing I really harp on because it's so much more likely than an infection or hematoma. And so I really talk to them about what it is, why it happens, what they could expect if they have a CSF leak. And then I bring it up again in pre-op. There are lots of things that could happen, anesthesia, et cetera. I mean, I suppose you could have like a nerve injury, but the likelihood is, that is very uncommon. And so, at least in my practice, I feel like it's good to harp on complications that happen. And this is one of them. So patients are pretty well prepared, God forbid, if it does happen. And then, in terms of trying to get a sense of the incidents, I think collecting your own data is good, and the slide is a bit of a joke, with Big Brother and everything like that. But I do think that there are probably efforts by insurance carriers to get a better sense of our risks for all complications. And this study is interesting because it kind of takes a different approach. It uses a natural language process identification algorithm, meaning it basically uses AI or a form of AI to look at op notes and certain terminology like Durgen or dural rent and things like that. I think that it helps determine the incidence of CSF leaks, and that actually has a higher, 8.4%. So if you pool revisions and stenosis and discectomy, that's what they came up with. I would be very surprised if our insurance carriers aren't doing something similar. Um, I don't quote 8.4%. I mean, that still seems high, but it may be accurate. I mean, this seems like the most sort of thoughtful study to try to get at a true incidence that I've seen, and it's by Dan Scuba and his group. Okay, so in that study, which I think is probably the best one we have, what are the risk factors that stood up to multivariate logistic regression? Well, there are a couple. Increased surgical duration, that's a little bit difficult if it's the chicken or the egg. I mean, certainly if you have a CSF leak, you're going to have a longer duration to repair it, but nevertheless, that was associated. Older age, there's no question that the dura changes as we age. In cranial surgery, when you're turning a cranie in an older person, the likelihood of ripping the dura is way higher just because the dura gets so paper thin, it gets stuck to the skull. You don't have that same phenomenon in the lumbar spine or in spine surgery in terms of the dura getting stuck, but it definitely thins. And so it's just more friable, more vulnerable to injury. The third is probably the biggest, at least in my experience and in my hands. I mean, revision dramatically increases the risk of spinal fluid leakage for obvious reasons. Planes are distorted, there's scar, there's adherence. It requires more force sometimes to get where you need to get through the scar. And so that all just leads to a fairly significant increase. Um, and then cases starting after 4 p.m., which, I think we all would hate to admit, but presumably after a long day, maybe we're not as um, ready for the task or tired or fatigue plays in. There was not any mention of synovial cyst, and I don't think this applies to all synovial cysts. Some have very good dissection planes, but in a certain subset, maybe 20% or so, where they've hemorrhaged, and you'll see venous blood, dark blood, almost like motor oil in the cyst. Um, they can become very adherent. And so I think if you try to get that adherent cyst off the dura, that can lead to leaks. And oftentimes you just kind of have to fenestrate it and just leave the portion that's attached to the dura behind to mitigate that risk. But I would say age and revision are probably the greatest risk factors. Things that are not risk factors, obviously no difference between neurosurgeons and orthopedics. That is not an issue. Maybe surprisingly, there's not a big difference between PGY level of resonant, at least at the MGH and Hopkins where the study was performed. You know, the hope is that you do get better at avoiding complications like this as your training progresses, but perhaps the younger residents had more supervision, and that's why there wasn't a significant difference. Mean years as surgeons since training, that did not satisfy statistical significance in the multi-variable regression. My guess is most of us probably get a little bit better at it. And then mean BNI, and I think, especially in MIS, the bigger the tube or the longer the tube, the less dexterity you often have. And my guess is it's probably a real factor, but maybe insufficiently powered to find that risk factor with statistical significance. So, often it's sort of thought of as a minor complication, unintentional, incidental durotomy, and certainly it happens to all of us, and that's maybe perhaps why we consider it minor. But it can have pretty dramatic consequences, both medically and legally in this instance. So, in this study, and it's a bit antiquated now, it's from 1995, but about 23 of 146 cases in spinal malpractice were related to an incidental durotomy. It was the second most frequent occurrence. So I don't know if that stood the state of time. I mean, it's almost 30 years into the future now, but there is some precedence for this being a significant medical legal issue. What are those consequences? So there's immediate and there's long term. Headache obviously is a immediate and potentially long-term consequence. So when folks have intracranial hypotension that can cause stretch on the dura, obviously there's no pain receptors in the brain itself, but if the dura stretches as a result of that diminished pressure, that can cause a noxious stimuli and postoperative headache. Um, One, sort of somewhat tragic consequence of CSF leak is even when the leak is repaired, sometimes folks will have continued headache, and it can be a real challenge. And often the hypothesis is that the leak hasn't been adequately fixed. But I've seen some patients that have had like, really dramatic and comprehensive workups, whether it be myelograms or spinal angiography, all these different studies to try to find evidence of continued leakage, and oftentimes to no avail. It seems as though the leak is fully repaired, but they do still have headaches. So it is potential long-term sequela. But in general, once the leak is repaired, the headache improves. Um, this is probably the second biggest consequence. The risk of infection is dramatically higher. And so if you've got standing fluid in a wound, that is obviously a very hospitable environment for bacteria. And obviously, if you've got a access to the central nervous system, that can very quickly turn into meningitis, which is exceedingly dangerous if not appropriately treated. I think from a meningitis standpoint, the one benefit is that people don't get meningitis in like a very subtle way. Usually when you get meningitis, you get pretty sick. And so it comes to medical attention and it can be appropriately treated. But I think if you've got like a pseudomeningocele or some standing fluid, the risk of getting like a P. acnes infection or a more indolent infection is extremely high. And I would say over the years, a significant portion of the postoperative infections I've had have actually been in the context of maybe a repaired CSF leak or a CSF leak that went unrecognized, which is pretty uncommon, but certainly increases the risk, and you want to plan for that. Um, there is, at least statistically in this study, some increased risk of new onset neurologic deficit. I have not seen that. I think the one caveat might be if you get some kind of like disastrous CSF leak and nerve roots are exposed, then obviously the risk of some kind of neurologic deficit goes up. That is sort of a separate category where you've got like major portions of the dura missing, and certainly those can be very challenging to close primarily. And then pseudomeningocele obviously can have consequences as well. The infection risk we already spoke of. So obviously, patient quality of life outcomes are going to be compromised in the short term if they're dealing with a complication, and this is no different. And so pretty dramatic effects on EQ5D and also the SF36. Accordingly, dissatisfaction rates are much higher, up to 50% higher. I had this little clip art or image of the Hulk. Some of you guys probably don't remember the Hulk because you're too young, but he was a pretty big pop culture icon in my era, and he was like a before I don't know what the current wrestling company is, but we had the WWF, and he was sort of their main protagonist. And he had surgery at the Laser Spine Institute, the since defunct Laser Spine Institute. And I think there was a bunch of things that went wrong. He had some kind of spinal cord stimulator, I think, that got infected. You can read all about it, but he ended up getting a pretty handsome settlement, and I think it was part of the ultimate demise of the Laser Spine Institute. I think much to the benefit of probably spine as a field. But in addition to dissatisfaction, it is obviously exceedingly costly. And the cost comes from increased hospital length of stay. So in my practice, if I, say I have a one level LAMI, they're generally going home unless they're in their 80s or have some kind of medical comorbidity that I want to monitor overnight. But for the most part, they're going home. Obviously, if you have a CSF leak, I don't send folks home. There are some people who will send folks home after a CSF leak through an MIS tube. I just think that's kind of setting yourself up for, potentially a delayed presentation or infection. So I never send folks home. I usually keep them flat the following day. And so there, right there, you've got 2 extra days where you're going to have an outpatient surgery. So that cost can be proportionally, very, very significant. Most of those folks are going to go on antibiotics, and then oftentimes revision surgery is necessary. So it can be, quite a bit more costly than the actual index surgery. There are a couple of studies that look into this. A study of Medicare databases shows about 4,000 increase per patient, which is a 67% increase. Pearl Diver, which is probably a little bit more granular and it goes out to 90 days, so it would capture some of those readmissions, suggests it's more like $10,000 more, which is 120% higher. And the rate of readmission, as we mentioned, is up to twofold higher, and the hospitalization extension is 1.5 to 2 days longer. So obviously, the most important thing is that it affects our patients negatively, but it also does have a pretty significant burden on our healthcare system. So it's going to happen despite all that. So it's bad. I don't think we should consider it minor necessarily. I think we should consider it common. But when it happens, it could be minor if it's appropriately addressed, or it could be very consequential. And so that's why I think when it does happen, it's really important to kind of just focus and come up with the best solution. And it is going to happen regardless of whether you're ortho or neuro, regardless of whether you're in year 20 or year one. And whether you're a PGY1 or a PGY5 resident. And although it is technically minor, as we mentioned, it can have major sequela. So I think management is critical because it will happen to all of us. And the first step is just not panicking, especially early on in practice. And this quote, I don't know, it's totally random. Is just, tell yourself that you're not a loser. You're not someone whose mother loved your sister more than yours. It happens to everyone. I think I was probably speaking about myself there, but there'll be time to blame yourself later. At the time it happens, just lock in. And maybe most importantly, don't pretend it didn't happen. I think there's a natural predilection to try to maybe just cover it up, or if I put a little piece of, um, Durgen or something like that, or cottonoid or some Surgiflow, and it's not really leaking. Maybe it's just synovial fluid. Um, I would argue that that is the wrong approach. And if you have an indice of suspicion, dealing with it at the time of surgery and exploring it is way better scenario than dealing with it in a delayed fashion. So what do I do? Um, if there's a, say I have a durotomy with a kerosene or, the Woodson tool or something like that, I'll kind of cover it up temporarily. I'll just make sure that I have the field sort of in a situation where I can deal with it. Take a deep breath, collect yourself. And I don't really say this to myself anymore, but I definitely did in the beginning. Now I think it's self-evident, but I strongly feel as though the index surgery where you have the durotomy is going to be the best chance for you to fix the problem for the person. And I've helped with many revisions of other folks, and certainly gone back and fixed them on my own. And I think going back to fix it is always more challenging. The best time to fix it is the index surgery. And so don't dwell on the fact that it happened. Just really focus on the best way to fix it at the time of surgery. And principles of management, there's no substitute for a good primary closure, bringing the dural edges together as opposed to just an onlay graft. There's no substitute for a good primary closure, and there's no substitute for a good primary closure. So I feel very strongly about that. It's not always feasible. Certainly if the drill hits the dura or something like that, and there's actually a dural issue, you may not be able to get a primary closure. Like Ollie and I did a meningioma on Tuesday. The meningioma was so enmeshed with the dura, that in taking the tumor out, we had like a M&M size hole where there was just no dura. And so there are times where you have to do inlay onlay grafts and things like that. But when possible, when feasible, a good primary closure is definitely the way to go. So in line with that, to optimize your primary repair to get that primary closure, oftentimes it requires expanding the incision, particularly if you get a durotomy that's kind of by the nerve root sleeve or maybe at the caudal aspect of your lammy. You need to be able to see it to repair it. You need to be able to get a full sense of how far it extends. And so you want to have full access both to the cranial and caudal extent of it. So fully expose it, and then there require a little bit of drilling or kerosene work, but really see it, really get a sense of what's going on. I think you're always at an advantage using the microscope just because you can see things, with greater detail, obviously. The micro instruments are critical, particularly if you're doing an MIS because they're bayoneted. The best microset scripts that I found, which I recently found about it, I don't know, 10, 12 months ago, is actually the ortho microset. So you guys have a really good microset. It's got those bayoneted blue needle drivers and better than the one that I was using. So you use if you're here at Scripps, ortho microset, and you got to figure out what works best for you. I mean, there's different things that are available to folks. This is a paper that looks at the choice in stitch. Folks use 4.0, 5.0, 6.0. I like 5.0. Gore-Tex, Prolene, or Nurlon are good. They're non-absorbable, which I guess is important. The reality is, I mean, by the time a absorbable suture would absorb, the durotomy should be closed and healed. So I don't know why so much is made about that, but they're very strong. And then perhaps the most important is this third variable. You don't want a stitch where the actual needle is of a larger caliber than the stitch itself. If that's the case, and you've got a thick needle or a needle that's greater in caliber, then when the stitch is thrown, there'll still be some room circumferentially around the stitch for CSF to leak out. So that's one thing I think that's important to pay attention to. But Prolines and Gore-Tex sutures, of that size, 5.0, I mean, they're made primarily for dural closure. So those ones I think you don't have to worry about. But if you use a different stitch for whatever reason, just make sure you take a quick look at that. It'll be on the package. I actually, for the most part, like silk, which is a bit of a zag. The reason for that is this gentleman here on the right, Paul McCormick, who is a prolific spinal tumor surgeon, and I was very fortunate to spend hundreds of hours with him when I was a resident, and he used silk, and so I just became comfortable with it, or I guess used to using it, and the reason primarily is because it handles really well, and silk ties, I think, very well. It doesn't absorb quickly, and to get good solid knots and just to get a good primary closure, I think is probably more important than the actual composition of the stitch itself. Meaning, if your stitches are in the right place and your knots are tight and the dural edges are very well approximated, I think that is probably more important than the actual makeup of the stitch. So I like silk. I've certainly used Gore-Tex before. The needle on the Gore-Tex sutures is often the smallest, which can be beneficial, particularly for rents that are close to the axilla. So just figure out what works for you. Most people, I think, like Gore-Tex. What about sealants? So this is a commonly used adjunct. The most ubiquitous one is Duraseal. And the common use is basically you try to close it primarily, and then you put some kind of graft on it, and then sealant, like graft being something that's collagen based, like Duragen. And that did lead to the lowest leakage rate after repair, about 5.5%. But the actual sealant as an adjunct, as opposed to just the primary closure, did not significantly reduce the rate of CSF leakage compared to just a primary closure. Again, speaking to the importance of getting that primary closure. So in other words, adding Duraseal, in this study at least, not significantly change the rate of failure of CSF leak repair. So I still use it, but I don't think that should be thought of as sort of the main closure. If you do, you're going to be in trouble. And then there's the philosophies of like how to place sealant. I've seen it every way. Do you put the sealant down and then you put the detergent over that, or do you put the detergent down and the sealant over that, or do you do sealant then detergent, more sealant? I don't know if there's a right or wrong way. I think again, statistically, it's really going to be more about the primary closure and less about all of this. But generally speaking, I'll do the repair, the patch, and then the sealant over that, just to kind of keep the patch down over the repair. There are some folks who feel like if you use the sealant primarily, it can interdigitate with the suture line and prevent it from healing, which is why I like to have the patch down over at sort of protecting the suture line from the sealant. No data to support that. In fact, the data says it doesn't really matter. But I would just think the important takeaway is that the sealant is not the primary closure mechanism. It is an adjunct and not one that we even have great statistical significance behind. Couple other, I think, less frequent ways to close the dura. There is this clip system that was designed. It is technically stronger if you read this paper, but it's also extremely difficult. In order to get these clips applied, you have to have both leaves of the dura, in a apposition enough to place the clip. And if you're throwing a suture, obviously you don't have to have that. You can do one at a time. So it's hard for me to see a context where this would really be useful other than planned durotomies when you have the two leaves of the dura, just lined up for like a tumor or something like that. So I don't think this is going to be increasingly prevalent in clinical use. More recently, and this is one of the two new slides, we have this Durastat device where it has these two separate bayoneted stitch extensions that are part of the same suture, and you can basically spring load one side, get the dural stitch where you want it, and then you fire it like a gun, and it very quickly shoots the needle through. I've had mixed results. I mean, sometimes I feel like it doesn't shoot sort of as you'd want it to. It's also $800 per stitch, which I know if you get a good dural closure, then the economics make sense, but it's still sort of a mental block for me to spend $800 on a suture. So I don't use it as much as I maybe thought I would when I first played with it on a model. I think the one incidence where it's really or the one scenario where it's really helpful is for those lateral or sort of axilla area dural tears, because you can throw a stitch at an angle that your hand just can't articulate, especially through a tube, which is what the model shows here. So I would never use this for like a run-of-the-mill dural tear, but if there's some kind of exotic tear, I'll probably use this just to try to get the two leaves of the dura opposed, and then I'll buttress it with a regular stitch thrown through, the micro neural set or the micro ortho set. So it's an option. I don't know. My hope is still that they can improve sort of the dexterity of it, but it works okay. And again, in limited circumstances. This is the slide I'm actually most excited about. So last year when I gave this talk, I didn't know that this existed. It is a collagen-bound vibrant sealant. It's made primarily for vascular surgery, so it's used to be placed over like venous tears and things that can't be directly repaired by vascular surgeons. Someone at some point realized that it might be good for dural closure. The way I learned about it is through Ryan Khanna, who's one of our recent fellows, and I don't know if he learned about it from Rush or from um, Sloan Kettering, where he was prior to coming to us, but he somewhere along the way picked it up, and it is awesome. And the reason it's awesome is twofold. The first is it's really sticky. So basically, you'll cut a piece and you put it over the durotomy site, and you'll get it wet. And unlike Durgin, which will kind of float away and is just easy to move or peel off, this actually sticks down and becomes really sticky. And so it will stay over the dural defect. And I think one of the issues with Durgin is that the pressure from the fluid will actually make it float away. This stuff is super sticky. And then it also kind of creates like a mechanical barrier. It's almost, sometimes for difficult dural tears, we would like sew a little muscle plug in to try to create some volume and sort of scarring. This kind of does that on its own. So it's really pretty pretty awesome. I don't have any data, although in this study, they obviously looked at it. Interestingly, they didn't have a huge statistical benefit that was found in this study, but I'm very bullish on it. So we'll see next year. Maybe I'll have some more opportunities to use it, and I'll have a little more to say. But the one downside is it's super expensive. I think it costs probably just as much, if not more, than an Durastat stitch. But at least in my hand, this actually makes a difference, and so I can justify the cost. Yeah, so I like this a lot more than Duragen. Drains, the fellows know, I am like maddeningly idiosyncratic with the drains, but I think they're super useful and they give you a lot of information. I think that's probably the benefit of the drain. Obviously, do not place them to suction. They cannot be placed to suction. But if they're on gravity, then you'll know if there's a CSF leak. I mean, if you've got a drain on gravity and it's putting out pink fluid, well, then you know that there's still CSF that's being, placed into the wound or expelled into the wound and then out the drain. But if you've got a drain to gravity and there's no CSF coming out, that's a pretty reassuring sign. So generally, and finally, protects against the one-way valve effect, and we'll go over that in the next slide, I think. But basically, my uh, algorithm is I will place a drain to gravity, usually a small hemovac, and then after a day or two, if it looks like things are progressing as they should, so say surgery's on Monday, I'll keep the drain to gravity on Tuesday. They're getting up on Wednesday. If it looks okay, then I'll actually clamp it to just pressurize the system, and then I'll open it the day they're about to go and make sure that there's still no CSF coming out, and then I'll pull it. But I just like having it. I like to know that there's not an ongoing leak, and if there is, then it gives me, information about that as opposed to the patient, coming back 2 days later. So I like the drain. Not everybody does, but definitely don't place it to suction. That one-way valve effect. So you can imagine, how this would work. But basically, CSF can get out of the fecal sac when there's still an opening. It can't get back in, and so if that happens, particularly in MIS cases where there's a really small wound, then that potential space can very quickly become filled with CSF, and it can become pressurized. And that pressure can cause deformation of the fecal sac and can cause quite a bit of issues related to that. So you would think that once the pressure in the potential space equilibrates with the pressure of the fecal sac, that no more fluid would come out. But in reality, when folks are valsalvaling or exerting themselves or what have you, that intrathecal pressure can increase and allow more fluid to be expelled. And so the pressure externally on the fecal sac can build up pretty quickly. And obviously, the drain gives you a way to combat this if you realize that an ongoing CSF leakage is present. And then flat protocols. I know that this is something that people have different thoughts about. There are some folks who don't even do it for what they think are well-repaired dural leaks. Whether you've had an iatrogenic durotomy or a planned durotomy, I pretty much always have a day of flat protocol. I do think that it's beneficial. The thought process behind it is, I think, well delineated from that water bottle on its side. If you've got a water column, a contiguous water column, and it's upright, well, that water column is going to collect at the bottom. If it's on its side, it's going to more equally distribute, and as a result, take less pressure off of the healing site. Obviously, it has the greatest effect in the lumbar spine because that's at the bottom of the water column, and so there's the most pressure on it. However, I still do it in the cervical spine, and the reason for that is it's not like your dura in the spine is half full. I mean, it's less pressure if there's an ongoing leak, but the water column extends all the way to the ventricles, and so it is still part of that water column. And so I think there's benefit for flat protocol even in the cervical spine. Generally, it's one day. So if somebody has like a spinal tumor or an iatrogenic durotomy on Monday, I keep them flat Monday, I keep them flat Tuesday, and then Wednesday morning, I sit them up. Wednesday afternoon, I get them up. I still have with physical therapy, I still have the drain in place. So I can see if them getting up and walking around does lead to any leakage of fluid. If it doesn't, then I generally feel pretty good about it. I'll pull the drain and they can either go home that day or the following day. When to place a lumbar drain? Basically, if you're asking yourself if you need to place a lumbar drain, is the answer to that question for the most part. But I think, if you're closing dura and you still see some visible leakage of CSF because you just can't get a more robust closure, then I think, you really should place a lumbar drain. And the thought process behind it is that by diverting CSF, you're depressurizing the fecal sac. You're giving the area where the injury to the dura is time to heal. So not something I ever do routinely for like tumor surgery or something like that. But if I'm taking a patient back to the OR for a CSF repair that didn't take the first time, or if there's any, question, I think it's a reasonable thing to do. It's not a difficult procedure, especially with fluoroscopy in the OR. You can do it in lateral cutis position. If I'm in the OR, I do it prone on the Wilson. If I'm at the bedside, which I fortunately don't have to do as much anymore. When I was a fellow, we had to do, or a resident, we had to do lateral decubitus at the bedside all the time. But for the most part, now I just do it prone on the Wilson, and you can just do conscious sedation. It's very fast, it's very safe, it's very easy. And you'll just see an image, something like this. You'll look at the MRI real quick, get a sense of where their conus medullaris is, maybe where their surgery is. You don't want to go through the old surgical incision. You don't want to go through the wound if you can avoid it. So try to find a virgin area that won't create a defect going into a potential space. Look at the MRI, get a sense of where the conus is, and then plan accordingly. If I'm, say I'm going to put her at 2-3, for example, well, I'll probably make the initial skin opening or skin puncture at 3-4 because you're going to be moving caudally with the needle to kind of get underneath the lamina. And you can switch between AP and lateral if you're having a hard time to make sure that you're in the thecal sac. I'm not going to go through all the steps of placing a lumbar drain, but if I'm doing one, whether it be for normal pressure hydrocephalus or a spinal case, just come check it out, Mike, David, any other fellows, just so you kind of get a sense of all the parts. I mean, the only hard part of the procedure is making sure you have all the right supplies and you know how they all interact. Mike, our fellow from 2 years ago, made I think a Google Doc, which is probably helpful, and you might get that from him, just about the steps and the supplies. How long somebody's on a lumbar drain is variable, and determined by their nature of their opening. If you have this scenario in practice, you can always call me and we can kind of talk through it. I will let them have 15 degrees for meals and for the bedpan. Obviously, a little bit of head elevation is not the end of the world. I generally do 12 Q2, meaning 12 cc's of CSF every 2 hours. I've 10 to 20 is within, I think, reasonable limits. I do it intermittent, so it's a little easier for the nurses. They just open up the drain, let 12 out, close it. Some of my partners feel strongly that it should be continuous, and you just keep the drain open and you raise and drop the bed in an attempt to kind of titrate it to that amount every 2 hours. That can be pretty challenging if you're not in the ICU. So there are different strategies there. And then this is a critically important improvement. So when I was a resident, we just had like regular Buritrol. I could collect however much CSF, 100 cc's. The Limitor system is something that was created because of patients that had fatal subdural hematomas as a result of iatrogenic overdrainage. So obviously, you don't want to drain too much CSF. This has a floating valve inside the collection Buritrol that will occlude the aperture after 20 cc. So basically, it won't let you drain more than 20 cc's at a time. Obviously, if the nurse or staff or whomever forgets to close the CSF drain, or if it gets inadvertently opened, this would protect against dramatic overdrainage. So it's very important. Make sure you have this at your hospital, Mike and David. It's called Limitor. Any questions you can ask me. And that's all I got. So kind of an interesting talk to give and to have so many hits on YouTube for. I wish it was something cooler, but it is nevertheless an important topic.
Super useful though.
Yeah.
Super useful.
Yeah.
I thank you, Hannah. It's awesome.
Yeah, of course, man.
Couple points that I've picked up along the way, and for you, especially the fellows to be aware of. be aware that if you don't repair, you can get nerve roots knuckling through these sites, and that can cause rictus. So it's not as simple as fluid dynamics. You can actually have some issues that are related to the patient neurologically and may not be very favorable. And then in terms of ergonomics, one of the tools that occasionally can be helpful and just ergonomically might be or can be more capable than the typical micro instruments is actually the micropituitary. Just a little more nimble in certain ways in handling the needle, depending on where the tear is. Like they're often not where you want them. They can be pretty disadvantaged locations. And then another trick that, and this relates back to the nerve root knuckling. If that's happening intra-op and it's hard to manage it, you can throw a kind of a loop suture through a little piece of Duragen or gel foam, and then stick it through the hole. So you've got control of it. It doesn't float away, and that sort of plugs the hole up and gives you control of the edges without the nerve root, being pressed through the CSF intrathecal pressure. Anyway, just a few
Yeah,
added pearls.
that's a great pearl. We used to call that parachuting.
Yeah,
So
exactly.
yeah, so that's a
Yeah,
great.
yeah. The idea is like a pledget for a vascular suture for a vein. They
Yeah.
they oftentimes will use a pledget. This is the same thing as a pledget for a vein tear. Yeah.
Speaking of veins, Bruff, have you seen that taco seal stuff?
No, but I've heard about it. So you can use it for this as a
Yeah,
sealant over. Oh wow.
yeah,
I mean,
yeah.
I've only used it twice, but it seems like it works really well. It's like
Yeah,
very,
I
it's
totally agree.
like
I
very
got
sticky.
introduced. I got introduced to Taco Seal with our vascular surgery colleagues. They use it a lot for like ALIF approaches. But I saw Hani use it that case we just had, and boy, it worked really well. It really stuck to the dura nicely, and it really sealed things up quite well. So I was pretty impressed with how it worked in that application.
And Handy,
Yeah,
you touched on this a little bit too, in terms of certain tears really do not allow them to be easily repaired with suture. The location of a tear is key. If it's down along the sidewall, if it's over the nerve root, boy, you're better off using something like a sealant rather than trying to place a stitch because you can capture a nerve root. So that's a huge. And when
yeah,
you're in there, yeah, for the guys who haven't are learning still, you got to know also when to fold them. When to hold
yeah,
them, when to fold them, right?
yeah. And I think in that instance, so you're absolutely right, Jamie. So if capturing a root or something like that is in the build, if that's in play, you obviously they won't throw out the baby with the bathwater. So in that instance, I'm hopeful that Tacoseal will be a very nice adjunct. And the reason for that is like trying to place a Durgen and getting it to stick in the lateral dura, particularly if there's CSF coming out, it's pretty challenging. It wants to float away. You kind of have to figure out a way to get it to stay there. But so oftentimes we'll put it in Durgen and we'll try to glue it in place. But I think that Tacoseal will really, hopefully, improve upon that. So we'll see. And I've used it twice, but I'm optimistic at a minimum.
Agreed.
Do you guys have any
And let me
advice
give.
for sorry, go ahead, Dr. Roby.
No, go ahead, Mike. Ask a question.
I was gonna ask about like traumatic durotomies that you can't really repair or control. There's not much to do about that as far as I can tell. But I was just wondering if anyone had any thoughts on that. I'm talking like, we had essentially a transected cord that you can't really do much with it repair wise. But anything we can do to help afterwards, I'm not sure.
I mean, I think the most you can do, Mike, and this is the case, the gentleman with the motorcycle.
Yeah.
Yeah, I think the most that you can do is try to reconstitute the sac to the extent that it's possible with some kind of grafting. So there's suturable and there's non-suturable Duragen, and whether you use that or Tacoseal, but I would try to reconstitute the sac. That's kind of like it's always an improvisation. Fortunately, I don't have to do many of those, but it's there's a level of improvisation with some of these dural pairs. You're never going to see the same one twice. But I think trying to reconstitute the sac is important because it'll probably eventually pseudomeningocele. So you try to reconstitute the sac, you try to get a really good fascial closure, and you just hope that you'll be able to create a pseudo capsule that will keep the CSF in place.
Okay, awesome. That makes sense.
And then I'm going to make one final thing or comment, and a lot of it has to do with what Bob taught me a long time ago in the selection of burrs and everything else. You know, a lot of your best strategy for dural repair is dural tear avoidance.
Yeah.
So right, right. So technique, you know, how you use the burr, you know, the burr that you choose. Obviously, a cutting burr will have a much higher risk of tearing the dura than a grinding burr like a diamond burr. So there are techniques, you know, leaving the ligamentum flavum intact until you're ready to remove it. It's the last thing that comes out, doing your bony work first. These are the things that I've learned over 20-year experience to kind of say, okay, how can I minimize my risk of tearing the dura, even in the most complex situations? Leaving the medial wall of the synovial cyst adherent, just leave it there. Just debulk all around it, but leave that medial wall that's stuck to the dura. It's not going to be compressive anymore. Leave it be. Just work your way around it, get above and below and lateral to it, and then debulk it as much as you can. Those are the kind of the tricks. So you're not, you know, dealing with all this stuff in some cases.
Good thoughts.
Yeah, Andy, great talk. Really good talk.
Yeah. Tour de force, Andy.
Yeah.
Andy, you're the CSF guy, Andy.
Yeah.
And Hanny, I always go to my self-deprecating husky person that I was when I was a child. The minute I get one, I'm that boy in those pants, just so depressed.
That's why we have such good personalities, Jamie.
Yeah, I know, right? We're those guys. It's like, of course, we're right back in that 13-year-old shame when we tear the dura.
You don't need to wear husky jeans. It's fine.
It's okay. I'm all right. I'm gonna be okay.
Yeah.
All right.
Okay,
Good
man.
talk.
Thanks, Andy.
Have a great day.
Thank you.